Hello everyone, I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about urinary incontinence. So what we wanted to discuss today? The mechanism of micturition, the definition of incontinence, the prevalence and the risk factors, the classification of incontinence with different types like stress incontinence, urge incontinence, or mixed type, or retention with overflow incontinence, and functional incontinence. So this will be ended with treatment options for urinary incontinence. Let us start our journey with the mechanism of micturition, and please look to this picture. You should know that micturition is a dynamic physiologic process consisting of alternating storage and the expulsion phases. So we have storage phase and the expulsion phase. And this is accomplished by complex interaction among innervation, smooth muscle, connective tissue, urothelium, and supportive structures. So I need intact anatomy of the urinary system, intact physiological mechanisms and reflexes between the higher center in the brain, the cerebral cortex, and the bones and the medulla, and the spinal cord and the ganglia, to the receptors in the muscle wall and the mucosa of the bladder, and smooth muscle of the internal sphincter. Okay? Okay. As you see here, the parasympathetic fibers run through the pelvic nerves, gives sensory to the mucosa of the bladder, and the motor to the smooth muscle of the bladder and the internal sphincter. This is the efferent fiber carrying the sensory from the mucosa to the ganglion and spinal cord, and the bladder receives motor impulse parasympathetic through the pelvic nerves to the detrusor muscle and internal sphincter muscle. Okay? These parasympathetic nerves and containing also another rather than parasympathetic somatic fibers, somatic motor fibers through the pudendal nerve. These somatic fibers gives innervation to the external anal sphincter through the pudendal nerve. So I have autonomic one, parasympathetic through the pelvic nerves, sensory and motor, and I have also somatic motor fibers through the pudendal nerves. What about the sympathetic fibers? Sympathetic fibers coming through the hypogastric nerves from thoracic 11 till lumbar 1. Okay? This is the sympathetic innervation and the parasympathetic innervation to the bladder. All these should be intact and all reflexes should work properly to keep the storage and the expulsion phase doing very well. Okay? So what is the definition of incontinence? Incontinence simply means involuntary loss of urine, which is objectively demonstrable, and this problem is a social and a hygienic one. Of course, irritating many people all over the world. So, is it a big problem? Yes. The estimation of prevalence ranges from 3 to 55%. There is variation between studies about the prevalence, but at least 50% of adult women will complain of incontinence in their life. Imagine how big is the number. On the other side, within nursing homes, 60 to 70% of patients experience the disorder of incontinence. What are the risk factors? Multiple vaginal deliveries, multipara, women in older age, smoking, diabetes. Diabetes, as we all know, can cause peripheral neuropathy, can affecting the bladder by different means. Obesity, incontinence is more common in obese patients. Long-standing constipation, or having a birth defect that affects the structure of women's urinary tract. So, classification of incontinence. We have important types like stress urinary incontinence, urge incontinence, mixed form, retention with overflow, and functional incontinence. So we wanted to know the definition of each one. Stress urinary incontinence, there is involuntary leakage of urine that occurs with increased intra-abdominal pressure, as during effort, during sneezing or coughing, due to urethral sphincter and or pelvic floor weakness. What is the common age? The common age between 45 to 49. Okay. What about the urge? Urinary incontinence is the involuntary leakage of urine that may be preceded or accompanied by a sense of urinary urgency, but also can be asymptomatic in sometimes. Why it happen? Due to detrusor overactivity. The contractions may be caused by bladder irritation or loss of neurologic control. Which age is common in urge incontinence? The older women, especially women above 60. So, stress urinary incontinence in younger women at the age of 45, while urge incontinence is very common in older women above 60. What about mixed urinary incontinence? Mixed urinary incontinence is the involuntary leakage of urine caused by a combination of stress and urge urinary incontinence. What about the overflow urinary incontinence? It is the involuntary leakage of urine from an over-distended bladder due to impaired detrusor contractility and or bladder outlet obstruction. So we have two factors here for overflow urinary incontinence considered as a cause. Either impaired detrusor contractility or decreased detrusor contractility, or bladder outlet obstruction. So give me example for this. For impaired detrusor contractility, it can happen with neurological disease like spinal cord injury, multiple sclerosis, diabetes. Okay. While for bladder outlet obstruction, the example include uterine fibroid, any other pelvic mass, extreme organ prolapse, pelvic organ prolapse. Okay. All these can cause compression, so cause obstruction. Okay. So overflow urinary incontinence is involuntary leakage of urine from over-distended bladder due to impaired detrusor contractility or bladder outlet obstruction. Lastly, the functional urinary incontinence. This is the last type. What is the functional urinary incontinence? It is the involuntary leakage of urine due to environmental or physical barrier to toileting. What does it mean? The patient wanna to micturate, but the environment is not suitable. So the bladder is distended until incontinence occurs. Or there is physical barrier. The patient is bedridden, cannot help herself, cannot toilet herself. Want somebody to help her to go to toilet. So this functional urinary incontinence can occur due to environmental or physical barrier. Okay, so let us look to this table because it is important, which summarizes the classification of incontinence, the pathophysiology, the symptoms, and the profile of the patient. Let us start with the urge incontinence. What is the pathophysiology here? Detrusor overactivity. And there is neurologic disorder or spinal cord injury. What are the symptoms? Loss of urine accompanied by or preceded by strong desire to void. May be accompanied by frequency and nocturia. Frequency of micturition all over the day, or nocturia means the patient wake up at night more than once to micturate. This is the meaning of nocturia. So this is the symptoms of urge incontinence, and this is the pathophysiology. What about the profile of the patient? Most common in older adults, as we said before, especially 60 years old or more. Also, there is a strong association with the stroke. Let us go to the stress incontinence. What is the pathophysiology? Increase urethral mobility or intrinsic sphincter dysfunction. What are the symptoms of stress incontinence? Loss of urine with physical exertion or increase in intra-abdominal pressure like sneezing, coughing, or laughing. What is the patient profile? Most common in younger women, age of 45, for example. And this is the second most common type in older women. So what is the first common type in older women? It's the urge incontinence. What is the second one? Is the stress incontinence. Be careful about this. Okay? Let us go to the third type, mixed type. We have here, as a pathophysiology, we have a mixed etiology between urge and stress. What about the symptoms? Combination of urge and stress symptoms. What is the profile of the patient? Overall, most common type. This is overall most common type. Okay, let us go to the other types of incontinence, which is overflow incontinence and functional. As regard the overflow, what is the pathophysiology? There is anatomical obstruction or impaired detrusor contractility from neurologic disease or diabetic neuropathy. Okay. What is the symptoms in overflow incontinence? Dribbling and or continuous leakage associated with incomplete bladder emptying. So this incomplete bladder emptying making the urine accumulate inside the bladder, over distending the bladder until incontinence happens. What is the profile of the patient? The bladder outlet obstruction is uncommon in women. Of course, it is commoner in male due to prostate, but it is uncommon in women the bladder outlet obstruction. More often occurs because of neurologic disorder. So the commoner as the etiology is neurologic disorder rather than bladder outlet obstruction. Okay, let us go to the last type, which is the functional incontinence. As regards the pathophysiology, maybe cognitive, mobility, or psychological impairment. What are the symptoms? Loss of urine associated with inability to toilet because of impaired cognitive, psychological, or physical function. The patient may have any psychological disease which prevent her from toileting herself, like Alzheimer or other diseases, okay? Or physical problem. The patient may be bedridden because of certain problem, certain disease, okay? So she cannot toilet herself. So she cannot reach the toilet to evacuate the bladder. So either psychological or physical or impaired cognitive considered a cause of functional incontinence. As regard the profile of the patient, more often occur in patients with arthritis, gait disturbance, or dementia. Let us explain more of these types of incontinence. As regard the stress incontinence, what is the etiology? Two main factors. Urethral hypermobility constitute the majority, 80 to 90% of patients, or intrinsic sphincter dysfunction constitute 10 to 20%. As regard urethral hypermobility, may follow trauma or stretching following repeated vaginal delivery, or due to post-operative complication from hysterectomy, or with hormonal changes related to menopause, or maybe a congenital weakness is the cause, or maybe pelvic denervation during surgery, during pelvic surgery, or maybe congenital weakness, as I said before. What about the intrinsic sphincter dysfunction? May be due to multiple period operations or radiation, exposure to radiation, radiotherapy for pelvic malignancy, or due to trauma, or due to neurogenic disorder, or due to atrophic changes due to lack of estrogen as in post-menopause women. What are these symptoms and signs? The classic symptom is stress incontinence. Frequency and urgency and the urge incontinence may be present. Genital prolapse, the patient may complain of swelling descending down with coughing or sneezing and disappear with lying down, as in genital prolapse. This swelling, of course, appear at the vulvar region with descent of the anterior vaginal wall and the bladder wall as in cystocele. Okay, so the patient may complain of swelling that appear at the vulvar region, increase with coughing and the stress and the sneezing, and decrease in lying down. Signs: urine leaking from external meatus during stress in absence of the detrusor instability. Female epispedias may be present as a congenital anomaly. Anterior vaginal wall descent in 50% of cases can be found, as in cystourethral. No special neurological or general features. What are the grades of stress incontinence? 3 grades. Grade 1 demonstrated with severe stress. Grade 2 demonstrated with moderate stress like rapid movement. Grade 3 demonstrated with mild stress as during standing. How to diagnose stress incontinence? From history, examination, investigation. From history, the type of urine loss, spurt or dribble, stream or drops, and to differentiate stress incontinence from other type also. History of traumatic delivery. What are the factors that increase incontinence? Is it with erect position? Is it with full bladder or not? Any previous operation for stress incontinence was done before? The patient is receiving certain drugs like psychotropic drug or drug that affect the autonomic nervous system because it may be an etiology. Any symptoms of associated prolapse like swelling at the vulvar region, like heaviness and so on so. Any symptoms of chest infection, and this symptoms of chest infection like cough and so on, it will cause increase in intra-abdominal pressure. Diagnosis from history, examination, like physical examination, chest examination for any chest infection, and the neurological examination for any disorders. Pelvic examination include careful observation of the type of loss, spurt synchronous with stress, so it is true stress incontinence. So while you are doing local pelvic examination and you're separating the vulva, the post labia minora, ask the patient to strain or cough, you will see spurt of urine. So this is diagnostic for stress incontinence. Okay? Dribble or stream during and after stress, denoting there is detrusor instability. Okay? To differentiate between both. Some clinical tests may be needed, like Poni's test, Yusuf test, holding test, and so on, and we will discuss later on. Examination of the anterior vaginal wall and try to exclude the presence of associated fistula. Evaluate the degree of cystocele in cases with pelvic organ prolapse. Local neurological examination can be done like sacral reflex. What about the clinical test? Clinical tests include stress test, Pony test, Yusuf test, micturition test, or holding test. Stress test, the patient in dorsal position, as I said, and you separate the labia, asks the patient to cough. If spurt of urine comes, this is positive stress test. But if no spurt of urine, you can repeat it in erect position. Repeat the test in erect position. And the aim of this test to identify the true incontinence. What about Pony test? If you discover there is a stress test positive, okay, repeat the test after placement of 2 fingers on the anterior vaginal wall around the urethra and the bladder neck. What is the aim of this? Is to identify whether stress incontinence is due to intrinsic weakness of the sphincter or due to anatomical descent. Okay. What about Yusuf test? In case of Yusuf test, the patient is continent. So she has no problem as regard the incontinence of urine. Is continent. But I need to do this test for a reason. I do this test in patient continent while she has the pelvic organ prolapse by pushing the cervix upward with valcellum and ask the patient to cough. If urine escape, this means continence was due to exaggerated uretrovesical angle. So the patient has hidden incontinence. But she is continent now. Why? Because with severe degree of prolapse, there is exaggerated uretrovesical angle, making the patient continent. So when I push this cervix upward, in its place, the continence appear. The incontinence appear. It's proved to be incontinent. Okay? Is it important? Yes, because you will be blamed if you repair the prolapse without doing something to support the bladder neck as a sling operation. The patient will be incontinent post-operative. A while before the operation, she was continent. She has no problem as regard the urination. She has no incontinence. But after you did repair for prolapse, she becomes incontinent. Of course, you will be blamed because she already had a hidden incontinence and you didn't do Yusuf test to discover this hidden incontinence, okay? And now, if you discover this, you should do sling operation or bladder neck plication with cyst-to-seal repair to prevent occurrence of incontinence after repair. Lastly, a test called micturition or holding test asks the standing patient to stop micturition suddenly. Okay? If unable, this indicates weak pelvic floor muscle and the urogenital diaphragm should be tightened with cyst-to-seal repair. Pelvic floor repair. Okay? Okay. What is the investigation needed? Urine analysis, of course, important, and you should exclude urinary tract infection and do culture and sensitivity test and manage the patient if proved to have an infection before you confirm any diagnosis of incontinence. Take care about this point because it is important. Bad test or 1 hour test. Give the patient the bed, clean bed, dry one. She applied on the external genitalia and move around for 1 hour. Then lock to the bed if it is soaked with urine or not. Ultrasound. Do ultrasound post-micturition and estimate the remaining urine volume in the bladder. How much is the amount of urine post-micturition? This residual urine is important. Cystourethropy to detect any urethral bladder lesion. Cystourethropy also to detect any lesions and any fistula also. Urodynamics is important for diagnosis of incontinence in general, including cystometry, measuring the filling and the voiding pressure, intra bladder pressure, also measuring the urethral pressure profile through special catheter and the bladder pressure, uroflowmetry while the patient using chair, and electromyography. So cystometry, urethral pressure profile, uroflowmetry, and electromyography is a component of urodynamics. What is the treatment? Maybe conservative, maybe surgical one. What is the indication of conservative? Maybe the patient unfit for surgery, or she wanted to be pregnant later on, so delay any operation until the patient complete her family because there is a risk of recurrence, or patient refuse to do surgery, so you will use conservative treatment, or uncontrolled detrusor instability or voiding difficulty. What are the forms of conservative treatment? Maybe pelvic floor exercise, maybe using vaginal cones actively or passively exercising the pelvic floor, or using several mechanical devices to occlude the urethra or support the bladder neck. Encourage her to use absorbent pads or wearing tampons or reusable foam pessary, or sometimes may need continuous indwelling catheter, but of course continuous catheter will be something irritating to the patient. Okay, use also electronic vaginal devices, short-term electrical stimulation via vaginal or anal routes. So you tried the behavioral therapy, pelvic exercise, electronic vaginal devices, electrical stimulation, and so on to make the pelvic floor muscle strong and can improve the condition. What about surgical treatment? If we have prolapse, pelvic organ prolapse, we can, like cystocele, we can do anterior colporrhaphy with Kelly bladder neck plication or Kennedy suture, or we can do abdominal bladder neck suspension like retropubic bladder neck suspension as Marshall Marchetti Crand's operations, or Birch colpo suspension, or laparoscopic retropubic suspension, or we can do paravaginal bladder neck suspension and do paravaginal defect repair, vaginal obturator shelf procedure, or use needle suspension procedures, or sometimes you need operation to correct incontinence which happen due to intrinsic sphincter deficiency by using a sling operation, and you can use either organic material, autologous or heterologous material, or synthetic material. Periurethral injection can be done using Teflon paste or collagen, or doing artificial urinary sphincter. TVT, which is the abbreviation of tension-free vaginal tap, involves insertion of Prolene tap underneath the mid-urethra through a very small vaginal incision with two tiny abdominal incisions. It is self-retaining and doesn't require any fixation. Let us go to the urging incontinence. What is the etiology? Maybe emotional disturbance, neurologic disease, or bladder disease like tumor, stone, cystitis, or increased or altered bladder microbiome. The bladder microbiome is bacteria present in the urinary bladder, as for many years it was suggested that the urine is sterile, while the GIT has normal habitat bacteria, and vagina also has normal inhabitant bacteria like lactobacilli and so on. Recently, it was suggested that the bladder may have normal bacteria, but these bacteria cannot be identified by the conventional methods used in the lab for analysis of urine and for culture and sensitivity test, but can be detected by certain procedure using gene expression and so on. So this is the altered bladder microbiome, which is changed with the age also, and this is recently discovered because the old spoken in literature say that the urine is sterile until reaching the urethra. This is a rule that was said in the past. Okay? Okay. Sometimes for urge incontinence there is no defined etiology. Okay? And this is many cases with urge incontinence, idiopathic etiology. What is the clinical presentation? The patient presents as urge incontinence. She has a strong desire to void. So, women typically complain of urgency followed by large loss of urine. Okay? The woman feels the desire to micturate, but before she reaches the toilet, urine pass involuntarily. The patient complains also of frequency and nocturia. There is association of frequency and nocturia with urge incontinence also. She may pass urine with sight or sound of water. Why it happened? Due to irritability of the bladder muscle, detrusal, instability, and so the patient cannot inhibit it. Advancing age is an important risk factor in case of urge incontinence. The treatment may be behavioral therapy treatment. Try the bladder retraining drills. The patient is asked to pass urine every hour during daytime and increase the interval by 15 minutes every week until she passes urine every 2 to 3 hours. Or you can use medications which inhibit contraction of the trusor muscle. You can use anticholinergic drugs and the beta-adrenergic agonists, tricyclic antidepressants. What about overflow urinary incontinence? The etiology, as I said before, may be either the trusor underactivity, which include impaired or decreased trusor contractility. Okay? Or bladder outlet obstruction. So, what are the causes of the trusor underactivity? Diabetes, due to peripheral neuropathy, for example, neurological diseases like multiple sclerosis, or bladder fibrosis. By the way, overflow incontinence can occur after vaginal delivery, especially if epidural anesthesia was used. And I have seen a patient post-cesarean section with overflow incontinence, and the bladder was distended, largely distended. Okay? And the only what happened is this situation happened only after cesarean section, maybe due to epidural anesthesia in some cases. Okay, so overflow urinary incontinence may be due to the trusor underactivity, and we said the causes: diabetes, neurological disease, bladder fibrosis, anesthesia, or bladder outlet obstruction like uterine fibroid, severe degree of pelvic organ prolapse, or post-surgical obstructions. What is the mechanism? There is insidious failure of bladder emptying may lead to chronic retention, and finally, when normal voiding is ineffective, it will cause overflow incontinence. Treatment, in short, just relief of obstruction, clean intermittent castorization or indwelling urethral castor, use of medication like alpha-adrenergic antagonists or blockers, like, for example, tamsulosin. Look to this table, please, because it is very important. It summarizes the treatment options of all types of urinary incontinence, okay? Please look here. We will start with urge incontinence. What is the conservative management? Weight loss in obese patient, fluid reduction, constipation management, bladder training, pelvic floor muscle exercise, electric stimulation of the posterior tibial nerve. What is the pharmacologic treatment? Anticholinergic drugs, beta-adrenergic agonists, intravaginal estrogen. What is the surgical treatment? Neuromodulation, implanted sacral nerve stimulator. Use of implanted sacral nerve stimulator. Okay? This is as regard the urge. Conservative management, pharmacological management, and surgical management. Let us go to the stress incontinence. Weight loss in obese patient, smoking cessation, which is a risk factor, fluid reduction, constipation management, pelvic floor muscle exercise, okay, extracorporeal magnetic innervation, electrical stimulation, mechanical devices like pessary, like urethral plugs, okay? Okay. What is the pharmacological treatment in case of stress incontinence? Alpha-adrenergic agonists like pseudoephedrine and phenylphine. And what other medication? Duloxetine. What is the surgical treatment in case of stress incontinence? Sling procedures like suburethral sling with tension-free vaginal tap, pubovaginal sling, mid-urethral sling, urethropexy, needle urethropexy or retropubic urethropexy, or colpo suspension like Marshall, Burge colpo suspension, or Marshall Marchetti, or Crantis Brasides. Periurethral injection of bulking agent, as I said before, collagen or Teflon pass. Okay, what about mixed type? What is the conservative management? Combination of above treatment with focus on dominant symptoms. So the patient has mixed type, okay, both urge and stress. Which one will be treated? Because it is something confusing. You will focus on dominant symptoms, okay? What is the pharmacologic treatment? Medication focused on dominant symptoms, okay? Let us go to the overflow. As regard to conservative management, relief of obstruction, clean intermittent castorization, and the indwelling urethral castor. Okay? What is the pharmacologic treatment? Medication, alpha-adrenergic antagonist, or blockers, like tamsulosin. Okay? What is the surgical treatment for overflow? Sometimes you may need suprapubic catheter, but it is rarely needed. Okay? This is the last slide. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.